So welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olevsky, the host for the Vasculitis Foundation educational webinar series. I'm also a patient living with MPA vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education, and we'd like to thank our sponsor, Novartis, for supporting these webinars. In today's webinar, Dr. Ken Warrington will discuss Janus kinase inhibitors and their potential treatment option for vasculitis, specifically for Giant Cell Arteritis and Takayasu Arteritis. After we finish this webinar today, there will be a recorded version on the Vasculitis Foundation's YouTube channel, and anyone who registered today will receive an email with a link to it as soon as it becomes available. I would love to just tell you a little bit about Dr. Warrington. Dr. Kenneth Warrington is a consultant and the director of the Vasculitis Clinic in the Division of Rheumatology, Department of Internal Medicine at Mayo Clinic in Rochester, Minnesota, with a joint appointment in the Gonda Vascular Center. He joined the staff at Mayo Clinic in 2006 and holds an academic rank of Professor of Medicine, Mayo Clinic College of Medicine and Science. And Dr. Warrington's research and practice interests are in the field of vasculitis, particularly large vessel vasculitis. He conducts clinical and translational research and has published extensively on these diseases. So welcome, Dr. Warrington. We're so happy to have you here with us today.
Thank you so much, Kathy. I appreciate the kind introduction, and welcome to all of you. Thank you for your interest and for taking some.
Yeah, go ahead. I was going to say, before you share today, I think we're going to do the polls, if that's okay, and just ask our audience a few questions.
Absolutely.
I should say that right out so you don't have to switch. Okay, everybody, we have some questions we'd love for you to take a look at and answer, just to give us a feeling of who's with us today watching. You should be able to see those questions coming up now. We have 4 questions for you. I know some of you are just coming in the room. I am going to end the poll now so that Dr. Warrington can take a look at it and see what he thinks about some of these questions. You should be able to see that now, I hope.
I do, yeah. It looks like about half or so are not familiar with JAK inhibitors, so this is a good opportunity to learn about this relatively new class of medications for vasculitis. And I see that, a third of the participants have heard of these medicines, but maybe are looking for some additional information. So yeah, I think this is good.
Okay, great. Thank you, everybody, for sharing that with us. It does let us know a little bit about you. And Dr. Warrington now is going to go ahead and share his screen and teach us about JAK inhibitors.
Excellent. There we go. So yes, so welcome again, everyone. And again, I think this is a great opportunity to discuss this class of medications that has just kind of entered the field of vasculitis treatment. So here are my disclosures. And I should share that while these are my current disclosures, I will also be discussing a trial that we performed with Baricitinib. That's one of the JAK inhibitors, and that was funded by Eli Lilly. So what I'd like to do this afternoon is talk a little bit about what are these medicines and how do they work. Briefly, these medicines work by blocking, reducing signals that lead to inflammation. So obviously in a condition like Giant Cell Arteritis, like Takayasu Arteritis, where we know there is an autoimmune process, where we know there's inflammation of blood vessels, then reducing inflammation is really what we want to achieve, and these medicines help us do that. We have seen from trials published earlier this year that medications that block this pathway, this Janus kinase pathway, is effective for Giant Cell Arteritis. Of course, there's still more that we need to learn, but we'll talk about some of that data. And then finally, we'll discuss a little bit about what else is going on and where the field will likely be going in the next few years. So very briefly, here's a timeline regarding giant cell arteritis. And I like to review this because it gives us an idea of kind of where the field has been and then prepare us to where it's going. The first biopsy performed, the first temporal artery biopsy showing inflammation in the artery, was done here at Mayo Clinic in 1932 by a Dr. Horton. And that helped us understand that in this disease, there is inflammation in the arteries. But a lot of people still continue to have vision loss and blindness. Up to 60% of people with GCA would go blind in that era because they had no effective treatment. Cortisone was discovered here at Mayo Clinic. You see there Doctors Kendall and Hench, who eventually went on to win the Nobel Prize for the discovery of cortisone, which is really the chemical that's found in prednisone. Once they started to treat patients with cortisone or prednisone in the 1950s, they saw that they could prevent people from going blind from GCA. So that was a groundbreaking discovery. What happened though then is, of course, we and others became very aware of the side effects of prednisone. And so then there was this big effort to identify medicines that could be as effective as prednisone, but without the side effects that go along with that group of medicines, right? The side effects of glucocorticoids. But look at the big gap, right? 1950s, it was not until 2017, so almost 7 decades later, that Tocilizumab, that has been marketed under the brand of Actemra, was approved for GCA. So that was the first FDA-approved medicine after steroids that became approved for GCA. Now, research led to the development of these JAK inhibitors, and they were approved earlier this year. So 2025 is now our second medication that's FDA approved for GCA. So what about Tocilizumab? You may know it as Actemra. We have a biosimilar now called Tyenne. Why has that been such an important medicine for the treatment of GCA? Well, we know that it reduces the likelihood of flare-up, so it reduces relapses. It allows us to use less glucocorticoids, so less prednisone, meaning less prednisone-related side effects. And it improves the quality of life of patients with GCA, specifically, of course, health-related quality of life. So less flares, less glucocorticoids, better health-related quality of life. What does Actemra or Tocilizumab do? First, I will point out this guy, interleukin-6. It's a messenger of the immune system. For short, we call it IL-6. When IL-6 binds to these blue receptors, it sticks to the surface of cells of the immune system. Once it sticks to the cell, it starts the cell's machinery for the cell to become activated. So the cell is going to continue to amplify, to perpetuate that inflammation. So this IL-6 is messaging the immune system to be more activated. You can see here in the red, this antibody, Tocilizumab, that binds the receptor for IL-6 and does not allow IL-6 to bind to its receptor. So if IL-6 cannot bind to the cell, then it cannot activate the machinery inside the cell that makes the immune system revved up. Now, JAK inhibitors work a little differently. So you'll see that JAK inhibitors work actually by blocking the signal inside the cell. So we know again that Tocilizumab works very well, but it's not perfect. So some patients are treated with the medicine, but still have flares or relapses. Some patients have to stop the tocilizumab because it causes side effects. Those could be low blood counts, liver enzyme elevations, infections, etc. Even when we treat patients successfully with tocilizumab, once we stop it, then a number of patients are at risk for developing flares. So it's obviously not a cure. It works while the patient is taking the medicine, but if you stop it, the disease can come back. And of course, you're aware of other considerations, perhaps cost. There's now a biosimilar, I mentioned Tien, that has lowered the cost of these medicines, but there are still downsides. And tocilizumab is an injectable medicine. So no doubt we need other options that are not an injection, other options that help, again, reduce the amount of steroids that we give for these diseases. So here come the JAK inhibitors. So these JAK inhibitors, again, look at this side of the slide. So I mentioned earlier, for example, that immune system messengers like IL-6, they have to bind to the surface of cells, but then you have this whole machinery inside the cell. And one of the pathways that works inside the cell is what we call this JAK-STAT pathway. There are enzymes inside the cell that, again, turn kind of the immune cells on that amplifies inflammation. So now, instead of blocking up here, like we did with tocilizumab, we can block the machinery inside the cell with these JAK inhibitors. So they disrupt the message that cytokines, IL-6 and others, send to the cell to make more inflammation. So if we block this JAK-STAT pathway, basically, we can reduce inflammation. And these medicines first came on the market for rheumatoid arthritis, a medicine called Tofacitinib, marketed as Xeljanz. We know it works for rheumatoid arthritis, and then after tocilizumab, there were kind of sister medicines developed, those being Upadacitinib and Baricitinib. So now Tofacitinib, Baricitinib, marketed as Olumiant, and Upadacitinib, marketed as Rinvoq, are all approved for autoimmune diseases. And you see the long list down here: rheumatoid arthritis, psoriatic arthritis, other forms of arthritis, some skin conditions, and bowel inflammation like Crohn's disease or ulcerative colitis. So they have broad indications within the autoimmune group of conditions. But of course, today we're talking about vasculitis. So what has been going on with JAK inhibitors in vasculitis? Well, as you can imagine, it often starts in a petri dish in the lab, and it also starts with mouse models. Fortunately, the lab animals are not as cute as this guy, but we do use mice, right, in vasculitis research. And one of the most prominent vasculitis researchers is my colleague, Dr. Cornelia Wyand, who is a professor of immunology and has a basic science laboratory here at Mayo Clinic. And again, here's a little bit of timeline about GCA. I mentioned in the 1930s, the disease becoming apparent with the first biopsies being done, the discovery of cortisone leading to the use of prednisone. Mayo Clinic physician Dr. Hunder realized that the inflammation is not just in the temporal arteries, but it can extend inside the body to other arteries, especially the aorta, which is the biggest artery in the body. And then Dr. Wyand, again, has done a lot of work to understand why the immune system and how the immune system goes wrong and how this inflammation in the arteries comes about. But she also saw that in a mouse model of vasculitis, this JAK-STAT pathway, this signaling pathway, is present in the inflamed arteries of people with GCA. So again, the immune system is activated, And it's using this particular enzyme pathway, this JAK-STAT pathway, to basically amplify, to sustain that inflammation. Then she used JAK inhibitors in this mouse model, and she saw that the inflammation in the artery can go down with these medicines. Even more interesting, perhaps, is that by reducing the inflammation, she could also see that the lumen, so the inside of the artery, was less narrowed when the JAK inhibitor was given to these animals. So the artery in giant cell arteritis is not only inflamed, but it also becomes thickened and scarred. And that results in the inside of the artery becoming so small that blood is not getting through. If you give this JAK inhibitor, again, this is in the mouse model, they saw that not only does the inflammation goes down, but they can also reduce the amount of narrowing in blood vessels, which is, of course, really important, right? Because if you reduce the amount of narrowing, then you improve blood flow. So that's all well and good in the mouse, but what about in people? And this was the first study that we conducted here at Mayo Clinic. It was a very small study. It was with a medicine called Baricitinib, Olumiant. Again, this is currently marketed for rheumatoid arthritis, not for giant cell arteritis. But we did a small study, and we are grateful to the patients who agreed to be part of this study. It was in 15 people. The study was funded by Eli Lilly. And these patients received this Baricitinib, a pill, every day for 1 year. We also gave them a short course of prednisone. At the end of 1 year, we saw that the majority of these individuals, so 13 out of 14 people who finished the trial, so 93%, were able to come off their prednisone, and very few, only 7%, had a flare of GCA. Their inflammation markers, their sedimentation rate, and their C-reactive protein got better as they went through the study. So again, this was a small number of patients, but it gave us some enthusiasm, some encouragement to say that these medicines may be effective for GCA. Now, when you're tweaking the immune system, there's always a risk for side effects. And again, when we're dialing down the immune system, we expect to see some risk with infection. There was one individual who developed shingles, that's zoster, and low platelets, low blood counts. So some side effects, they seemed reasonable in comparison to the benefit of being able to come off prednisone and reduce the likelihood of flare-ups. But of course, with a small number of patients, that is not enough to justify the use of the medicine. After that, we saw publication of this landmark clinical trial called Select GCA. This is the trial that led to the FDA approving Upadacitinib, marketed as Rinvoq, for the treatment of giant cell arteritis. And I'll talk to you about how this study was designed to help you understand how the medicine is being used. So a couple of things to watch on this slide. Large number of patients, over 400 people with GCA. So that tells us this is a robust study because it's a large number of patients. The patients had to have either new GCA or GCA that was flaring. The most important piece to look at is the part up here. So the individuals with GCA received 26 weeks of prednisone, plus Upadacitinib, plus the Rinvoq at 15 milligrams once daily. So this is the group of patients who received the study drug. They also tried a lower dose of 7.5 milligrams, did not work as well, and so we'll not talk much about that dose. And then there's a group of patients where you have to have a comparison, right? So a group of patients who got placebo, so matching the Upadacitinib, looks the same, but is basically a sugar pill. And then they also got prednisone. And these individuals got prednisone for 1 year. So basically, we're comparing prednisone for 1 year versus prednisone for 6 months with the Upadacitinib, our study drug. Who were the patients? The patients were, as we would expect for GCA. You always want to see that it makes sense, right? And these were people in their 70s. Many of them were women. 2/3 had a new diagnosis of GCA, and 1/3 had GCA that was flaring. Many of them had symptoms of polymyalgia rheumatica, and 10 to 20% or so had problems with vision. So these are patients that match what we would expect to see in a clinic of patients with GCA. How did they do with the study drug? Well, so what the researchers wanted to find out is, did the patients stay in remission? So again, 2 things to look at in the slide. These are individuals who received prednisone for 1 year, 52 weeks of a prednisone taper. At the end of the year, you only had about 30% who were in sustained remission. That means that 30% had no flare-ups from month 3 to month 12. 30% is kind of low. That means that many patients had flares of GCA as they tapered their prednisone. This is something we see in clinical practice all the time, something that is expected. Can we do better by giving Rinvoq in addition? And indeed we can. So you can see here that those who got Rinvoq 15 milligrams daily, plus 6 months of prednisone, almost half the patients or so had this sustained remission, meaning they kept their remission while they were in the trial. So the bottom line, talking it through different aspects, and another aspect that's important is that people who got Rinvoq got much less prednisone. So 1,600 milligrams in total versus 2,800 milligrams for the patients who got only prednisone. So the bottom line is that by giving individuals Rinvoq, there were more people who remained in remission, sustained remission. They were able to keep that remission going through the end of a year. Also important is they were able to get less prednisone. So you're giving less prednisone and you're keeping people in remission. That's what we want, right? The number of flares were lower and patients felt better. Again, there's a lot of details on the slide, but the bottom line is more remissions, less flares, less prednisone. Those are things that we like to see in somebody with GCA. Now, of course, whenever we're using a medication, we expect some side effects. Keep in mind that in a clinical trial, we record everything. Anything that happens to somebody who's in a trial, we have to document that for safety reasons. Common side effects were headaches, joint pains, elevated blood pressure. No surprise, some people got COVID. These common side effects were not necessarily different than when the patients on placebo were analyzed. So oftentimes you see these side effects happening in the 2 groups, but there were some things that happened a little bit more commonly in those getting Rinvoq Upadacitinib. Things to watch for here: shingles, zoster. So zoster was more common in people getting Rinvoq, about 5% versus 3%. Many patients, many investigators, physicians have asked, well, were the patients vaccinated? Had they had the shingles vaccine? And the bottom line is many patients had not had the shingles vaccine. So getting a shingles vaccine can protect against that. More people on Rinvoq had anemia, so low blood counts with the Rinvoq is still a possibility and is something that needs to be monitored with blood work. So the bottom line here, with JAK inhibitors in GCA, we see higher remission rate than those just on prednisone. With Rinvoq, there was less prednisone use, and it was generally safe and well tolerated. Of course, did some patients develop side effects? Yes. Happens with every medicine. The advantage is that it's a pill, it's not an injection, and it does appear, again, to be of benefit in giant cell arteritis. There are unanswered questions. At the American College of Rheumatology meeting just a few weeks ago, we saw some longer-term data, up to 2 years now of treatment. Of course, the one unfortunate aspect is that we saw in the newer data is that when the medicine is stopped, there is a risk of flare. So again, just like with Tocilizumab, JAK inhibitors work while the patient is taking them. There is a risk of flare-up after the medicine is stopped. It's important that we continue to monitor for side effects to ensure safety, and unfortunately, flares or relapses can still happen despite use of this medicine. Infection is a concern anytime we're tweaking the immune system, but that, of course, is also a concern with prednisone. Blood count changes, again, importance of monitoring blood work to make sure that the medicine is being prescribed safely. Now, there is another aspect. Those of you who may have taken the medicine or have read about the medicine will know that there is a black box warning on this medicine from the FDA regarding cardiovascular, so cardiac, heart-related risks. Where did that come from? That comes from this study. It's called the Oral Surveillance Study. Tofacitinib, so a sister medicine to Rinvoq, not identical, but very similar. I mentioned earlier that this medicine is on the market for rheumatoid arthritis. And to look at safety, the FDA required the company that makes this medicine, Xeljanz, to take a very large number of patients, right? They can do this with RA because RA is more common. So here you've got over 4,000 people. They were older individuals, and they had at least one risk factor for heart disease. So that could be high blood pressure or diabetes or high cholesterol. And they followed them for 4 years. So this is a very big study, and it generated important data. Again, it was required by the FDA for safety purposes. You can see here, some people got tofacitinib 5 milligrams twice a day. That's the current approved dose for rheumatoid arthritis. Some people got a higher dose. The higher dose is used oftentimes for inflammatory bowel disease. And then some individuals, so we have a 1/3, 1/3, 1/3. 1/3 were getting a medicine that's a TNF inhibitor, an injectable medicine called adalimumab, marketed as Humira. And they looked at side effects of these medicines. So what they saw is that the individuals who were getting tofacitinib, this JAK inhibitor, had a slightly higher risk of cardiac complications. So you can see here, now again, they're comparing one medicine, the TNF inhibitor, Humira, and in those individuals, about 2.5% had a cardiac event versus 3.4%, so about a 1% increase in the individuals who got the tofacitinib or Xeljanz. Now again, some got the average dose, some got a higher dose. Similarly, with all cancers, there was a slight signal in people getting Tocilizumab. This resulted in the black box warning that you see on this group of medicines. No surprise, again, a slight increase in the risk of infections. You see here 8% infections in those with Humira versus an increase by about 1 to 2% in those getting Tocilizumab. A higher rate of zoster shingles and a small increased risk in the rate of blood clots. Now, again, keeping in mind, these were not patients with GCA or Takayasu, so we do not know if these data apply to people with vasculitis. But because Upadacitinib Rinvoq is a sister medicine to this Tocilizumab, then the FDA mandated that these risks be available, be published to anyone who takes a JAK inhibitor. In rheumatoid arthritis, again, this study was with many more people and for much longer. And to look for rare events, you do need more people, you do need longer follow-up. In the GCA study, these risks have not been seen. Is that, so it remains to be seen, I think, with more data and over time, whether there will be the same concerns that we're seeing in rheumatoid arthritis. But for any of you who are on this medicine, Rinvoq, or interested in going on the medication, obviously we have to watch for infection. That's where vaccines come in to help reduce the likelihood of things like influenza, COVID, or shingles. Blood tests are important to monitor blood counts, liver tests, and kidney function. There may be an increase in cholesterol levels. And again, those are things that we can monitor with blood work. So I encourage you all to be attentive to doing the blood work on the schedule that's recommended by your provider. I'll spend a few minutes talking about Takayasu Arteritis because we have less information with this disease than we have with Giant Cell Arteritis. So Takayasu Arteritis, there have been a few studies with JAK inhibitors. So you can see here both Tofacitinib, Xeljanz, and Baricitinib have been studied. I'm not aware of data with Upadacitinib Rinvoq yet. With Takayasu being more rare, the numbers of patients in the study, remember with GCA, there were over 400 patients. Here you see with Tofacitinib 26, 32, 10. So the experience with JAK inhibitors in Takayasu is still early, still in smaller patients, smaller numbers, but we are seeing a signal of positive results. For example, here, Tofacitinib was compared to methotrexate. There were more people in remission, less flares, less prednisone use with the JAK inhibitor compared to methotrexate. Comparing it to leflunomide, Areva, seemed to be about the same in terms of clinical response, but patients were using less prednisone, and they seem to have improvement in their imaging studies, less inflammation in the arteries when they do scans, such as a PET scan. And then it was studied in 10 patients, specifically with Baricitinib with Olumiant, and again, 60% of the patients seem to respond. Now, again, it's early data. These medicines are not FDA approved in Takayasu, oftentimes because of the small numbers in the trials. All these studies were done in China, and so whether they apply, to patients who are in the United States is always difficult to compare. But it is encouraging that there is some preliminary data that these medicines are also effective for Takayasu Arteritis. So we still have work to do, right? So what are the next steps? The next steps are understanding which medicine works better for a particular individual. Um, it would be great for us to understand, in somebody with, for example, giant cell arteritis, should we right off the bat have them on Tocilizumab, or would Upadacitinib work better? That's again something that is still being worked on. What is the long-term safety? We know that giving the medicine for 1 year is fairly safe, but what if people are on it for longer? We need to study that. We do know that patients with GCA have some risks in the long term. We know that patients, you are often, I'm sure, asked to have scans to check the aorta, because we know that up to a third of patients with GCA may go on to develop widening, to develop an aneurysm of the aorta. We don't know yet whether tofacitinib or upadacitinib, so we don't know if Rinvoq or even Tozilizumab, Actemra, changes that risk. Whether they prevent aneurysms or not is not clear. So that is something that we need to work on to understand. So again, we have work to do, but it really is exciting to see new medicines being developed and being approved for the treatment of GCA. Again, because we want to use less prednisone, we want medicines that are safer and just as effective, if not even more effective. If you have interest in understanding kind of what are the clinical trials going on, clinicaltrials.gov website is really nice to see what is happening in giant cell arteritis, in Takayasu arteritis. Here's an example of a picture I took from the website. You see, for example, there are studies going on in China, again, looking at Takayasu arteritis, still examining these JAK inhibitors. We need more studies on biomarkers. We need studies on imaging, and some of those are ongoing, because oftentimes scans can really help us understand, what's going on with the artery inflammation on the inside. Gives us a better window into what's happening with inflammation in the arteries. So bottom line, I will conclude here by saying that these JAK inhibitors are offering a new way to treat GCA and Takayasu. They have a unique mechanism that blocks inflammation kind of inside the cell. It blocks the machinery that is driving inflammation. We know from this very large clinical trial in GCA with over 400 patients that the medicines work. But of course, there is still work to do to understand really kind of the full potential of these medicines and their long-term effects. So I will stop there, and then we can certainly go to the Q&A session here. And I thank you very much for your interest and for your attention.
Okay, that will be great. And we will move right. I was just going to say, if we can stop sharing, which you did, we'll move right into some of the questions. So we'll get as many as we can before our time is up. I did want to say to some of you, you did a great job with your questions, and we'll try and get as many of them as we can. I'm going to start with one that says, this person, you may or may not know these answers, Dr. Warrington, but this person has been on Actemra since 2020 when they were first diagnosed with GCA. And apparently their insurance company has let them know that in 2026 it won't be covered, and they're suggesting a biosimilar. This person is wondering whether Rinvoq should be considered instead of a biosimilar, or how do they compare the two, or how do they bring this up to their doctor?
Yeah, that's a really good question, mainly because we are seeing a movement towards more use of biosimilars, and we get frequent questions about that. Are biosimilars, is it okay to go from brand name Actemra to the biosimilar? And one of the ones I see used frequently is Tyenne, for example. This is a trend with all the biologics. Started with adalimumab, Humira, infliximab, Remicade. Basically, most of the biologics, rituximab is a similar medicine. it's basically the same as a generic medicine, right? For example, if you take a cholesterol medicine like Lipitor, there's a generic version, atorvastatin. It means that companies are making copies of the original drug. When a company discovers a medicine, they hold a patent. So for a number of years, nobody can copy it. Eventually, the patent expires, and other companies then start to make copies of the medicine. Fortunately, again, they are regulated, they are reviewed, and they go through an FDA approval process. So the bottom line is that biosimilars have to be and are considered just as effective as the brand name for them to be on the market. So whether to switch medicines, that's a very individual kind of decision. Oftentimes, if my patients are doing well on brand Actemra and insurance requires, which again, very, very commonly, insurances are moving to using the biosimilars, then we will often make that switch. Reasons to move from one medicine to the other, again, are individualized. Oftentimes we will switch medicines if the medicine is not working, if there are side effects, or if there are, insurance or cost reasons to switch medicine. If those reasons are not present, then we will often just go from the brand to the biosimilar.
Okay, thank you. There are a couple of questions, particularly about Actemra in here, and I'm going to try and combine some of them because I think they're sort of all asking similar questions. One question is, has it been compared to Actemra? So that goes along with the next one, which is, would I do only Rinvoq and not prednisone and not Actemra? So some people want to know is if you did Rinvoq, could you come off prednisone? Some people want to know, has it been compared? Like, is it as safe? And I think you're saying it's the doctor conversation about is it working for you? But I'm asking on behalf of three people with similar questions.
Yeah, yeah. No, it's an important, topic to consider. Short answer, there has not been a clinical trial comparing tocilizumab to upadacitinib and Rinvoq. There has been no head-to-head trial to date. So we have, a trial with tocilizumab, we have a trial with upadacitinib. They have not been directly compared. In individuals with new or relapsing GCA, whether it's tocilizumab or Rinvoq, they are always combined with prednisone. And then prednisone is tapered, and then, the other medicine, the tocilizumab or the Rinvoq, is continued. For a new diagnosis, for relapsing disease, they're often combined with prednisone.
Okay. I think that answered about five people's questions right there. So I just want you all to know I was trying to get most of you in that one thing. There was a question in here. Is there any evidence that it says TAKI medications? I think they meant JAK, or maybe are they effective in the treatment of polymyalgia rheumatica as well? I think they meant JAKI.
Yeah, so that's a topic of interest, and I am aware that there are studies looking at that. So those studies are ongoing, and no clear answer as yet. Again, there's some preliminary encouraging, data, but keep in mind that JAK inhibitors are not approved by the FDA yet for the treatment of polymyalgia rheumatica. So that's an ongoing area of interest. There's some preliminary signal, but we need data from large clinical trials that are ongoing to really answer that question.
Okay, thank you. And I think we all understand that we're waiting for that information. We do have somebody that asks some very specific information, so I'm going to generalize it for them. Hopefully, they will get the answers that they need. This person was diagnosed with GCA in January 2025, and they're seeing a neuro-ophthalmologist and a rheumatologist. And I think the concern is that the neuro-ophthalmologist has put them on prednisone, but the rheumatologist is not doing anything other than labs. And they're just worried that it's not being treated properly. Do you have some advice for them?
Sure. So we partner very closely with our neuro-ophthalmology colleagues. They are experts, right, in understanding the eye complications of GCA. They are able to look at the back of the eye, examine the optic nerve. They give us very valuable information about what's going on in the eye of people with GCA. At least at Mayo Clinic, it is the rheumatology team that really manages and basically prescribes, directs the medications. In the majority of people with GCA, we recommend a second medication, that being Tocilizumab or Upadacitinib or Rinvoq. So there are a few people where the medications may be contraindicated. There are very specific reasons where people may not be eligible for these medicines. But for the most part, rheumatology prescribes, manages the medicines for GCA. And again, in the vast majority of patients, we are offering a non-steroid medicine to help us do the things we talked about in the presentation, reduce the risk of flares, and reduce the amount of prednisone we use to help reduce the prednisone side effects.
I think that should help them go back to their rheumatologist and have a conversation. So thank you for trying to answer that. Here's an interesting question. How can inflammation be monitored when a person is on Actemra? Isn't sed rate and C-reactive protein not accurate when you're on Actemra?
Good point. Yes, it's a limitation that we are aware of. So when Tocilizumab, Actemra, blocks IL-6, it basically blocks the body's ability to make CRP. So CRP becomes normal, and it's not a helpful indicator in terms of how the disease is doing, whether the disease is active or not. So that's a limitation. So then we have to rely on symptoms, examination. That's why we bring patients in, right, for follow-up visits to examine them. And sometimes we have to think about whether scans, and those could be CT scans, MRI scans, or PET scans. In some individuals, we have to rely on scans to help us understand if the disease is active or not. Sometimes ultrasound. It's a tricky subject. We know there's ongoing research about that. We need better biomarkers. We need to understand how to use imaging better. So that's all going on in the research world. And in the clinical practice, from a patient to patient, again, it's monitoring symptoms, physical exam, and then partnering with the provider to decide when an imaging study, a scan, might be helpful. But that is a really important subject, and many researchers around the world are working on that.
Well, thank you for answering that. I'm going to again combine two questions that I think have a similar topic. One is, can JAK inhibitors stop my disease from, can it stop my disease from getting worse or damaging my arteries? And the second part of it would be, do the arteries narrow again after ending the JAK inhibitors?
Another important concept, right? I'll mention a few things to consider. One is we have become more and more aware of the chronicity of these diseases. So these diseases are chronic conditions. The medicines work when you're taking them. And unfortunately, when the medicines are stopped, there's a risk of the disease flaring. Difficult to answer the part about, do the blood vessels become more narrow? That's uncommon, but it can happen as part of a flare-up, especially in Takayasu even more so than in GCA. So yeah, we, of course, it would be wonderful to have a cure, right? A medicine that can stop the disease and stop it from coming back. We're not there yet, but we are excited to have new options that can help the disease stay under control.
Okay, thank you. I know that one was a hard one to answer, so thank you for attempting that for us. Um, is there, this person's asking, can this help, the JAK inhibitors, can this help with symptoms like headaches, vision problems, and fatigue?
Yes, they can. And that's what was seen in the trial, right? Obviously, no medicine is perfect, and no medicine works for everyone, but it was shown in that trial that if you look at a group of patients, right, clinical trials are there to evaluate what happens to a group of people, and you saw there were 420 people in that trial, and there were more people who felt better on the medicine than there were people who in the prednisone, the people who got prednisone only. But it's comparing groups of people. So how an individual responds is variable. Um, but yes, but if there are ongoing symptoms of GCA, Upadacitinib, Rinvoq is one option to consider.
Okay, thank you. And this person asked, what is the best imaging to review the widening of the aorta? The only test that showed my GCA was a PET scan, and it was in my aorta. PET scans are so hard to be approved by insurance. Do you have any recommendations?
Yeah, I thank you for bringing up the topic. We use PET scan. It is used. I understand the concern with cost. We're aware of that. Keep in mind that PET scan is best to look for inflammation. So PET scan tells us, is the aorta inflamed or not? If over time we are interested in understanding whether the aorta is widening, a PET scan is often not necessary. We can see widening of the aorta with a CT scan, with an MRI scan, with an echo, which is an ultrasound of the heart. So there are other ways to look for widening of the aorta that are not necessarily a PET scan. PET scan is best to look for inflammation.
Okay, thank you. And I had one person say, ask how long you can stay on tocilizumab safely. Are patients with GCA allowed to stay on this just to keep the relapses at bay?
Yeah, that's again a topic of ongoing research. We looked at the patients that we treat here at Mayo Clinic. There are studies from other groups around the world, and it is not uncommon for patients to remain on tocilizumab for a number of years, several years, 2, 3, 4, 5 years. Um, there are studies that have shown that the likelihood of side effects does not increase. Of course, at any time point, there's a chance of side effects happening. But it's not that, the longer you're on it, kind of the more problems that come up. It continues to work. So as long as, the patient is taking it, it continues to work. We need more research to tell us, how long an individual needs to be on it. But we are seeing that patients, remain on this for longer than we initially thought. There are a few countries around the world where their healthcare system or their insurance mandates that they stop it after 1 year. I know in the UK, that's a concern. Australia, um, similar issues. And unfortunately, if they only take it for 1 year, then many people will flare. So
Mm.
it seems to be needed for longer.
Okay, thank you. And a couple of people asked this, so I'm going to throw this in as our last question. I'm sorry if I didn't get to everybody's. I tried to, and we can get some follow-up with Dr. Warrington down the road. He's already said that he would help us with that next in 2026. This person says, my Actemra shows a low white blood cell count. Do JAK inhibitors do the same thing? my
possibly.
Actemra makes a low white blood cell count.
Yeah. We see that in people with Actemra at times. We so JAK inhibitors can cause that. It doesn't mean that both medicines will do the same thing in the same person. So in other words, if an individual has side effects of Actemra, it's not unreasonable to think about switching to something like Rinvoq. I will say, and I did not mention this in my presentation, but please keep in mind that the 420 patients who were in that Rinvoq trial had not previously received Tocilizumab. So basically, Rinvoq has not been studied in patients who had previously failed Actemra. So there are some unanswered questions. So bottom line is, yes, Rinvoq can cause low blood counts, but it's reasonable to trial the medication in somebody who has had side effects to Tocilizumab Actemra.
Well, thank you for sharing that, and thank you for answering all of the questions that you did and the great presentation today, Dr. Warrington. I wanted to tell you that I saw at least 5 comments about how people felt like they learned so much and that there was a lot of great information in your presentation today. So I always like to give that feedback if I can, and we're getting lots of hand clapping signals on the side. So thank you so much. And also, I know you're on a tight deadline. I'm going to just do a wrap up, but I wanted to start by saying thank you so much for your time with us today. And if you want to stay till I wrap, feel free. But if you have to go, we certainly understand. I will look for you as soon as I finish with the last couple of things for everybody today. Let's see.
Yeah.
So I'm going to just share my screen here so that you all can just learn one or two more things before we go. Just before we finish up, we want to remind our viewers to use the Vasculitis Foundation website, where you can find all kinds of help and information about forms of vasculitis like GCA and Takayasu. So, for instance, under education, you can learn about the various forms, but then you can go to a section called Order Print and get a short 1-page document that you can print out and take to any of your other providers. I keep telling people I took it to my dentist recently. And you can hand it to family members or people that don't understand your disease. The VUP website also has a great video library with these kind of webinars, and on the homepage you can find out more about the patient support groups or upcoming events like live webinars, as well as the conferences that have been all around the country this year. I would also just like to mention that they have a new Find a Doctor database, and it's just been changed and improved a lot. So if you're looking for a doctor or you're not sure you're with the correct doctor, please use their Find a Doctor tab. You can enter your location and what type of doctor you need. It's just a great new tool to help find the proper providers for the form of vasculitis that you have. And also in upcoming events, I just want to tell you about 2026. There's something called Navigating Your Vasculitis Journey. It's a course. It's a live 6-week virtual learning opportunity. It came out in the Vasculitis e-news recently, so you may have already seen this. But it's offering behavioral strategies to help those recently diagnosed with vasculitis manage life with a chronic illness. Under the Navigating Your Vasculitis Journey, using their guidebook for this, it's a free course. It brings participants together for 6 weekly 90-minute Zoom sessions to connect and learn and grow in a supportive setting. The sessions will be held on Thursdays from 10 a.m. to 11:30 a.m. Central Time, beginning January 22nd and running through February 26th. Participation in this course is limited. I feel like it was 20 people last year, but I'm not sure. Applications have to be received by Friday, December 5th. If you click anywhere on the screen right now, you'll get the link, and I think Ed's going to put the link also in the chat box. So having said that, I now need to just say thank you so much to Dr. Warrington. Thank you to the Vasculitis Foundation for these educational webinars, and to our sponsor, Novartis, for providing them. And everybody, a survey will pop up right as soon as you leave. It'll say continue. Please click continue. Take the survey. You need to tell us what you want out of these webinars. That's how we select the webinars for the next year. So thank you so much. And thank you, Dr. Warrington. I always appreciate how thorough you are and what a great webinar we had today with you.
Thank you, Kathy, and thank you all for your attention and for joining us this afternoon. Have a great evening.
All right, goodbye, everyone.
Bye-bye.